As you know, Dravet syndrome is a rare developmental epileptic encephalopathy. The majority of cases is linked to mutation of SCN1A that are linked to loss of function effects. And patients with Dravet syndrome have very complex and drug-resistant epilepsy, which is associated to developmental delay starting from the second year of life. And linked to that developmental delay later on, they actually develop attention problems, behavioral issues, since the pediatric age, but later on is linked to also other type of psychiatric disorders. And the tools that we've had since the first phases of the disease is actually the intelligence quotient assessment, so cognitive assessments, and also adaptive behavior scales have been used in assessing patients with Dravet. But all the tools that we've used since up to now, there's been tools validated on typically developing people or patients. And these tools actually, and there's very literature on the matter, have seen a floor effect. So patients with Dravet, we have we have issues in detecting the fluctuation of the functions of these people. So we actually cannot assess confidently the efficacy of the interventions that we do. Going, of course, beyond seizures, which is a goal that the community, with the help of patient advocacy group, have set themselves to help more of these people in their daily life. Also, what we've done is we've worked with the Paris Center, the Necker des Enfants Malades, to assess with the help of patients advocacy groups. And I have to thank Dravet Italia Onlus for this, and Mrs. Brambilla in helping us in developing this tool that we're confident will help patients with Dravet. We've in developing this scale, we've started from what we already use, the tools we already used, and we've tried to incorporate in the scale the comorbidities that I've just told you about. So, and the various domains, the first draft actually had 11 domains, and with the help of a pilot study that we did, a pilot administration that we did to a few people, we were able to change the structure and having 9 domains, which are both for developmental skills, so gross motor function, fine motor function, adaptive behaviors, but also other type of issues like behavioral issues. So we have a behavior subdomain. We have other comorbidity subdomain that also has sleep in it. And so we've tried to cover as many comorbidities and as many issues as possible. We were able to do a first evaluation on 80 patients with a very varied age. So the younger one at 3 years was 3 years old, and the older one was 41 years old. So then this is also very important because, of course, babies and toddlers have a different issues compared to adults. And so we were able to administer to 80 patients, and the mean time to administer the interview was 35 minutes, with a maximum of 60 minutes. This was very important because we don't want the administration to be, cumbersome for the caregivers that have to help us in the administration of this interview. And we were able to finish the administration in one sitting in the majority, in the 73% of the cases. But we had to do another separate interview to finish it in the other 27% of cases. And of course, it was administered to caregivers. In 79% of the cases, it was mothers, and in fewer percentage, it was fathers, which is something I think significant. So the next steps are, so we tried to correlate the results we had from the interview to these tools that we already use in the clinical setting and also in clinical trial settings. And some domains, some things that we measured correlated very well with these tools. But on the other hand, other domains and other things that we were able to measure did not correlate at all, which is something that is, in our opinion, significant. It means that we actually were able to measure something novel in this population. But there's a statistical issue, of course, in validating this. So now we need to do, and what we have done is administering the scale to the same population twice. So a retest paradigm. So we were able to enroll a further 50 patients in which we administer the interview, and then 2 weeks later we administer it again. And we see how the results are stable. And we are now in the analysis of this data, and so we expect to see certain stability in the items that have to do with the developmental skills. So because these patients very rarely actually lose a developmental skill, but their skills fluctuate. So we expect to see a certain degree of variability in the other items that we designed to actually detect this fluctuation, which can be very useful in the clinical setting. I would just like to thank again the group of Professor Nabut for the huge effort, and to thank again Dravet for supporting this effort.